All right. Hello, everybody. Thank you for coming. Just a couple quick announcements before we introduce today's physician. First, make sure to follow us on Instagram. This is our main form of communication with upcoming presentation, last minute updates, and everything like that. Also, make sure to join our email listserv. It's on our website. And make sure to follow us on LinkedIn and list us as one of your experiences. Um, Links for everything I mentioned and the quiz are going to be in our Linktree and our Instagram bio. So if you can't find any of those links, just head over there. And today we'd like to introduce Dr. Jeremy Grossman. He's currently a Med Peds resident at Stony Brook. He completed his medical school at Sackler School of Medicine, NYS, where he published an award-winning project on battling homelessness in Tel Aviv. He's continuing research on diabetes. In addition to his research, Dr. Grossman volunteers with Camp Conrad Chinook, I hope I said that right, a nonprofit camp for children with diabetes. After his residency, Dr. Grossman plans on becoming a hospitalist and working in primary care. So without further ado, Dr. Grossman, you can take it away.
All right, thank you. Hey, everybody, thanks for tuning in. I'm really excited to be here, really passionate about medical education and passionate about spreading awareness about the field of medicine. So I'm on the East Coast right now. I was telling the crew here that I am from the West Coast rather, and I work out in the East Coast. So right now I'm visiting family up in the Bay Area, if some of you may know it. So that's why there was a little confusion today with the timing, but looks like it worked out and we're all okay. So I kind of want today to be about you guys and making sure that I answer all the questions that I need to answer on your end to make sure if this is a field you want to go into or just if you have questions in general. I'm going to try to answer all the questions that the team here gives me through the chat, but I encourage you all to add me online on Instagram. I answer like direct questions there, and I'm happy to do that on my off hours and help you guys. When I was a med student myself, or rather a pre-med student, I didn't really have good access to that. So I guess this is a good thing that COVID has brought. Cool. All right. So here we go. I'm an internal medicine and pediatrics physician. So it's kind of a weird niche field where I'm getting double board certified in adults and kids. And it primarily focuses on inpatient hospital medicine. Family more along the lines of kind of outpatient. I mean, you do get trained in family medicine and outpatient, but this is kind of more geared to working in the inpatient setting. I chose it because I love adults and kids. I couldn't make up my mind, and I'm pretty happy about the choice that I made. What's cool, I guess, about today is I can answer your questions about the combined field, but I can also answer your questions about each individual field if you're interested in just going into adult medicine, just pediatrics. All right, next slide. All right, this is my Q&A slide. If anyone has any opening questions. Maybe we don't have any yet, it's early on.
I don't think we have any opening questions yet. Do you have time are you okay with doing them later on in the presentation?
Yeah. This is a pre-med, I couldn't predict how this was gonna go today, so it's all good. All right, so a little bit about me. I'm a senior resident. So, most residencies are anywhere between 3 years long. Some are longer if you want to go into like neurosurgery and you're crazy, for example. Mine is 4 years long because it's a combo of internal medicine and pediatrics. So each of those alone are about 3 years. So together they were able to kind of figure out a 4-year plan. That's it's like an accelerated plan that's really smushed together, and it's a big learning curve. You got to do a lot of studying and really those because you're competing with peers who are at any time a year to 2 years ahead of you that are at your same role. So, but there is a lot of crosstalk between internal medicine and pediatrics. I mean, medicine itself is definitely a spectrum. So it's not like mutually exclusive fields, right? If I'm a surgeon, I'm going to need to know, the anatomy of the gastrointestinal tract, and I'm going to need to know that as an adult doctor too. If I'm like diagnosing an X-ray on the floor, for example, I'm going to need to know if there is an obstruction or a fecal mass or whatever, if it's in a certain aspect of the tract, I'm going to need to know that, right? So there is a lot of crosstalk between the fields, and that's why it's so important that you're getting a general medical education with all the fields when you're in medical school. And that's not why each track is its own, because they're all really connected. And you have to actually know when you're going to be consulting each other field when it's out of your scope. Okay. So I'm a senior resident who's not a first year. A first year is an intern. They're just learning the ropes, figuring out how to do everything. And everything they're doing is essentially being watched and monitored. And there's multiple layers of protection because they're just, students who came out of med school. So they're not trained professionals yet. So that's what our roles are as senior residents, is to make sure that interns are doing well and to make sure that all the tasks of the day get done. And obviously we do have more knowledge and expertise in answering questions. And obviously anything that we don't bring up to the attending resident, or rather the attending level, and they can potentially answer the questions for us and solve the matter. But for the most part, I'd say, the resident team without the attending doctors can solve anything, anywhere from like 80 to 90% of the problems. And then the rest are kind of filled in by the attending. Okay. I live in Long Island, New York. That's where the hospital I work is. I have a dog, Zeus. This is Zeus. He's a 105-pound American bull. He's a cuddly dude. And he motivates me in everything that I do. I live for Zeus. All right, what's next? I play guitar. Cool. I play guitar. Yeah, I've done that. I don't have much time for that anymore. That's out the window. But maybe I'll pick that up again when I'm done with residency. But in all seriousness, you do have time to have fun. I just mostly lost interest in the guitar and I don't play it as much. But ultimately, you can have hobbies and have fun times outside of the hospital. And I think when I wrote these slides, I said I love watches. I guess I do love watches. I probably need to take that out. That's not like a redeeming quality. I don't know why I put that in there. But yeah, I like watches and I have like an addiction. Everyone's addicted to something. And I'm addicted to like going on eBay and looking at watches and buying them. So all right, let's move on before I like muddy this up anymore. All right, how did I get here? All right, so I grew up in Southern California, where my parents are. And I was like diabetes at a young age. So I've had it for, I don't know, like 18 or 19 years now. I've kind of lost track. So I was like in and out of the medical field. So I really got to know it well. And that's kind of what drove me to go into medicine. But initially it was more of along the lines of like, oh, I guess this is like what's for me. I like really don't know like what else is going to work for me. So I went into medicine, but later I found out I really did love it. So I lucked out in that sense. I went to University of California, Irvine campus, undergraduate. I majored in biology and I also majored in psychology there because I wasn't sure at the time if I was going to go to be a therapist or if I was going to be a doctor. Thank God I chose the doctor because there's a certain limit where I just can't listen to people talk for more than an hour because I just like fall asleep. And that's okay. You got to know what your strengths and your weaknesses are. I went to med school at Sackler, which is Sackler School of Medicine, which is a medical school in Israel, in Tel Aviv. But it's a New York State school. So it was like in the 60s, they made this like pact that like you would get your medical initial training out there. And then in your third and fourth years, you would come to the States and do your rotations. And then they basically like feed you into all the state residency programs in New York. So it's kind of a cool inter-country sort of deal. So I ended up at Stony Brook Hospital, which is a state university hospital. It's a good time there. Nice big hospital. I think it's like 600 something beds. The two towers there, that's the medicine building. The smaller building right in front of it, that's like maternity wards, the neonatal ICU where I was just working. And then there's some other new buildings in the back. That's brand new pediatric hospital. They have a surgical ICU. They got everything there. It's the place you want to go. If something's happening to you in Long Island, you should go to Stony Brook Hospital for sure. A bit about my residency program. I think I told you guys, it's 4 years long. It's gruesome, but it's doable. You can still have a life. A lot of fun people. I recommend, not worrying about where you're going to do residency and more about where you're going to go to med school, because you should take it day by day and step by step. I was telling these guys, if looking forward, if you're going into the future, you don't want to be like thinking about like 15 years down the road. You want to take it kind of one day at a time and max like 1 week at a time. Otherwise your mind's going to explode. Okay, cool. Let's go on. Why medicine? Ooh, look at this nice stock photo I chose. Wow, I don't remember fruit there and like a heart-shaped bowl. Wow, I'm so clever. So, okay, so why medicine? I think I told you guys I'm a diabetic. And I've been in and out of the medical field and I got into it. I felt like it was the right thing for me. You know, if you have somebody in your family that's gotten you closer to the medical field, that's awesome. If you haven't had that ability to like kind of live the life of a doctor, I recommend, obviously these tele-shadowing sessions are great. I know that there's multiple places that do this. That's good, but you should also definitely go and shadow people in person if you guys are younger in your years and COVID's starting to clear up a bit. So that might be a probability that you guys will be able to do that. I think that's pretty much it. Yeah. So, but well, the reason why you go into medicine is all up to you guys. So, if you have certain questions about that, or should I go into medicine, again, like message me on Instagram and we can talk. I like live for this kind of stuff. Having a little bit of diversity in your day is really important, right? So being a doctor, there's a lot of clinical work that's going to like happen on the floor with patients. There's a lot of administrative work, policy changes, projects that are going to change quality improvement in the workplace. There's like policy changes at the state and the federal government level. There's community-wide events, there's outreach, there's homeless projects. I mean, it's like, it's never ending. Too, obviously, is like international medicine, which is huge and a really big way to help people out. All right, cool. NAMPRA. So this is just, there's different resident organizations for each residency tract. So the National Med Peds Residents Association, I think, is a really cool website to check out, especially as not only as like a resident and as somebody who's interested in med peds, but more along the lines of somebody who's interested in the general medical field, because like medicine and pediatrics is like pretty much, it's like everything about medicine, and we really have to know about every age, every condition for the most part, even surgical ones. Obviously we're not doing the surgeries, but we need to know how to prep them, how to post-op them, etc., like how to manage those patients. So I think it's a really good intro into choosing, going into the field of medicine and prepping yourself for what a life in medicine is going to be. And then if you like to have like cool medical facts, you can grab that stuff there. AAF American Association of Family Practitioners is like so killer. It's got like great layouts on everything, and it's like fully publicly available. Like if you want to search like the workup for like a thyroid nodule, like they'll have everything there and you don't have to pay for it. It's like the wackiest thing. And like I use that over like some of the paid applications that my hospital provides me for. So it's really cool. It's a really cool place to check out. So if you're interested in certain things, I would definitely read that up. I'm sure a lot of you are getting into research too. So if you want to look at what the current guidelines are for certain conditions, and you want to build your like research project out of that with a PI or somebody like a professor that you want to work with, they're cool websites to check out. All right, next one. Thanks for switching the slides. I appreciate it. Okay, what's the next thing? What is a med peds doc? All right, so essentially I was kind of describing this before, but a med peds doc is somebody who is kind of like a family medicine doc, but we work. So if you go do a family medicine residency, I think I saw you guys had a family medicine resident on here at some point. They're primarily dealing with outpatient care, and they are able to do inpatient care, but they're not as well trained in inpatient medicine and in inpatient pediatrics. They're more like the jack of all trades. So they learn how to do adult medicine, pediatric medicine, and obstetrics and gynecology. So we remove obstetrics and gynecology, add that time into pediatrics, and then add another year into our training. So we're working for 4 years and just focusing on adults and kids. And that means we're well equipped to go to the hospital and work in the hospital primarily with inpatient acute care patients who really need help. And then on top of that, we're also able to go and specialize. So if I, for example, didn't want to work with kids anymore and I wanted to be an adult cardiologist, I could go do that. If I wanted to just quit adult world and be a pediatric ICU attending, I can do that, right? Double certified. And there's more and more programs that are actually being created. I think I had read that Med Peds was actually created around the same time family medicine was created. So it's been around, but it's not as popular because it's a very specialized thing and program that's, I think it's tougher to build inside of a hospital that requires a lot more resources and participation from internal medicine and pediatrics. What kind of patients do we see? Adults to everyone and anything. And when we try to do everything we can, and when it gets to the point that we can't manage it, we're going to obviously call that consult and ask somebody, hey, listen, we've got this patient. They probably, for example, like if someone came in for abdominal pain and we worked them up and said, okay, well, it's not gastrointestinal disease. It's not a gastroenteritis. It's not IBS. Oh, look, let's do an ultrasound. Okay, look at that appendix. Have appendicitis. I'm going to go ahead and call the surgeons, and they're going to take care of it. So we're going to take up to pretty much everything we can take, and we can really manage everything. And what's really cool about med peds is you're seeing the management of like primarily adult and primarily pediatric patients, and you're taking that management and you can apply it to the other in ways that peds residents and doctors might not be able to think or know about because they were never exposed to that adult way, right? So it's another cool thing that you can say, you learned in med peds. All right, next slide. All right, so here's the like layout. I think this is a really good picture. Again, I'm super clever of me to pull this up for you guys. So I'm totally joking, guys, by the way. Grace didn't smile. I'm relying on Grace to smile to give me the feedback if my jokes are good. And only Nicholas and Magdi. Is it Magdi?
Spot on.
Yeah. Okay. All right. So basically only these two laughed. So, and they had weren't laughing at my jokes before. So I had to gauge it. So I'll just feed off of all three of you guys. Okay. So back to the timeline. So undergraduate education, it takes 4 years, right? To go through med school. I think we all know that. Unless you fail, then it's going to take longer, or unless you're in those super accelerated programs and you're super smart, in which case, why are you on this talk? Go and study. What am I going to give to you? You're clearly smarter than me. So 4 years for most med school, right? Okay. And then before that, obviously, most of you, I assume, are in some sort of undergraduate education program. And so you guys should be taking your medical school prerequisites. And that doesn't mean you have to be a bio major or a chemistry major. You can really be any major as long as you take those prerequisites. So at my school, I probably shouldn't have been a bio major because I think my grades weren't as good as they. But probably to a degree, the medical schools appreciate when you are in a science major, because it shows how much harder you're working. But ultimately, if you're in another major and you just do your prereqs and you've got a stellar application already, then you're probably good to go. So again, like I said, I was originally bio, and then I was freaking out. I was like, oh, my grades aren't perfect. Maybe I'll just go to psych. So I started to switch to psych, and then I was like, I'll just do both. So I ended up doing both. And it worked out because I did a cognitive psychology path. So it was kind of fulfilled some of the class requisites in the medicine side, or rather the bio side. So it was neurobio type stuff. Okay. So 4 years undergrad, 4 years med school. I don't know why it says residency is 2 years. That's crazy. I don't know any residency that's 2 years. I guess this was a bad chart. So it's 3 years, minimum 3 years. I'll do another. I think ENT is 4 years. I think surgery is 5 years. I think neurosurgery is 6 years. Dermatology is 4 or 5 years. I could be wrong. So usually the sexier, higher paying specialties tend to the training is going to be longer, whether that means just residency or you have to throw on a fellowship, right? They say it's 1 to 2 years, which some of them are, but some of them are if you really want critical care, for example, I think has a 3-year fellowship. So a palm crit rather. So you have to keep that in mind, right? It's good to have goals and dreams, but also just keep in mind how long am I going to be in school? Am I going to want to have a family? Is this going to be something feasible? Am I going to want to live in the city? Am I going to want to live rurally? How, you should be thinking about how much money you're making. As a resident, you make anywhere from 50 to 80. As a fellowship, in fellowship, you make anywhere from 70 to 90,000 a year. So, and then obviously from there, you know, you can make upwards of you know, let's say $125,000, $150,000, depending on what your specialty is. Cool. So that's kind of the layout, right? And so you can see at the bottom there's a lot of tests you have to take along the way, which, you know, has a lot of stressors that come with it. You know, how are you managing stress? Do you have tools? And if you don't, you might not be able to make it through those milestone tests, exams that you have to take. So just keeping all the stuff in mind, it's very doable. I think I was like very much an average student. I worked my butt off. I worked really hard, but I don't think you have to be necessarily like quote unquote smart to be a doctor. I think it's about kind of being more street smart and knowing what your weaknesses are, what your strengths are, and how to react to those. And just working your butt off when your limitations are and to ask for help. So ultimately that's what you got to do. All right. Next question. Next picture. Typical day in the life. So this is me with some other med peds docs. Those are my two interns on the right. So I work with them on this is the general pediatric floors. You can see the bright colors in the middle there. This is a med peds doctor who actually chose to go into ICU care on the peds side. So now she's a PICU, a peds intensivist, who just works with very ill kid patients. And you know, it just kind of shows you the span of what you want to do. I think the guy on the right, he wants to go and do cardiology, med peds cardiology. So he wants to follow cardiac murmurs from young age to old age. This other guy, I've actually forgot what he wants to go into. Maybe he doesn't know yet. Maybe that's why I don't know. All right. So typical day in the life. Let's talk about it. So in the morning, I think this is a really important about, probably the most important thing I'll talk about all today is like what's it like a day in the life. So I was just telling the team here, I work anywhere from 5 to 7 days a week. It probably averages about 6 days a week, especially as a med peds doc. When you're always on the inpatient service, it's usually like a 6-day week and you get 1 day off. So I wake up, I have a dog, Zeus, as you guys saw. I wake up at like 5 a.m. I brush my teeth, I have a cup of coffee, I walk my dog, and maybe I watch the news a little bit. Maybe I'll chart review, look at some of my patients on the floor, and then I'll leave for school. I'll leave for hospital, and I'll get there around 7 a.m. And at 7 a.m., I get sign out from the night team, right? So there's day residents and night residents, and you rotate. So sometimes you're a day person, some days you're a night person, and so it's like the worst thing. I hate it because you're so tired when you switch and you're so off. But you get used to it though. You strangely like learn to just live tired. And when you're well slept, it's like weird. It's like, why do I feel so good? So in the morning around 7 a.m., I get signed up from the night team, and they go, all right, so Mr. Bobby, he had a heart attack last night, so he got transferred to the cardiac unit. So don't worry about him. Mr. Johnson, we think he had a stroke. We did a CT of his head last night. It was clear, but just in case, consider it, maybe there was a TIA. And then patient Johnny Jenkins, whatever, it's terrible name making. Johnny Jenkins had an earache, so we gave him some Debrox. It looks like he had some wax in there, and he says he feels better. So we said, okay, so I got signed up for my patients. And as the day doctor, I know way more about my patients than the night doctor, right? Because the night doctor is just responding to things. The day doctor is like making the decisions, figuring out what's going on from day to day, and what's going to be game plan, and when are we going to get this person out? Are we going to consult somebody for this? Is their treatment working? Do we need to make an adjustment to it? Do we need to get labs on them? What did their labs say? Do we need to make adjustments to those medications? Do we need to give him some fluids? Is he taking enough NPO? Is he going to the bathroom normally? Et cetera, et cetera. So we're just kind of responding and also trying to be proactive at the same time in the morning. So we take into all those accounts that the night team does. And then around 9 a.m., we round as a team. So I'm the senior resident, and I have my juniors, my interns, and they're going to present to the attending. And the attending knows everything about the patients. And the attending is basically, the guy who makes the decisions, or the gal who makes the decisions at the end of the day. So they're going to be the ones you report to and say, I'm doing this, this, and this. Or if you're the senior resident, you can make all those decisions, and then at every did, and they'll tell you, oh, okay, that was right, I like that, or no, I didn't like that, here's what we're going to do instead, and make a change to it. So typically the attendings definitely are on the safer side because their licenses are on the line. So if, for example, somebody had a headache, let's say, and had some weird neurological symptoms, I might say, well, I think it was just a headache or a migraine. I'm not concerned. The attending might say, well, we can't be totally sure, and they are in a hypercoagulable state, so maybe we should just go ahead and get that CT to make sure there wasn't any sort of stroke. So there's kind of a lot of back talk between yourself and the attending. And then, so that just happens throughout the day. And once we finish rounds, usually the attending and the interns write their notes, and I'm, as a senior resident, I'm managing, making sure we followed up on all the orders, making sure all the consults are put in, making sure I'm following up any imaging or labs that we ordered, and maybe check patients and responding to any emergencies that are happening. So once that happens, you essentially are going to sign out your patients to the night team. And hopefully throughout that day, you can get lunch, you can get a few cups of coffee, you can maybe meet a friend for a little bit. If there's a little downtime on the floor, have your co-resident or your co-intern cover for you while you have some downtime. So yeah, that's pretty much a full day. And it repeats itself and repeats itself, and you get better at it, and some things get boring and some things get more interesting, and sometimes you can learn to critically think better and understand conditions better, and hopefully by the time you're out, you can function on your own, as a full-blown attending. Go ahead, you can switch it now.
Sorry, my elbow hit my keyboard.
Yeah,
so.
You messed up. How did you really? Man. All right, do we have any questions? I don't know if we do.
Well, I've got some. So you were talking earlier about how there's like several layers, like a protective net between the interns and the patients in terms of patient care. Like there's layers of like security there. Can you tell us like how an intern might make like a clinical decision and how that goes through the ranks in terms of actually being done, like in terms of prescribing medication or ordering a test or anything like that?
Yeah. So the intern, or whatever you are when you come out, you can write orders and put an order in. But ultimately, every order you put in is going to be checked by somebody. So we'll go through the layers together. So the patient says, oh, my arm hurts, nurse, my arm hurts. So he'll tell the nurse, and the nurse will triage and say, okay, is this nothing? I'm just going to give some Tylenol. Or is this something that I, as a nurse, don't know what to do? I'm going to go tell somebody. So let's say she felt like, oh, it hurts. I'm not sure what it is. Let's say she gives him Tylenol. And over the next hour, it gets worse and worse. The nurse goes, okay, I don't know what this is. It's not working. I'm going to go tell the intern. So she goes to the intern and says, hey, listen, Mr. Johnson's arm is hurting him. We're not really sure what it is. It's weak. He's got some numbness and tingling. His vital signs are stable. But he says he's in a lot of pain. He didn't respond to Tylenol. Like, we need to do something. And so the intern goes, okay. So maybe we should go try something. So maybe we'll try something stronger. All right, let's take the dose of 0.5 milligram of morphine. And so he'll do that. He or she will do that. And then he or she will tell me, we'll give him a 1/2 dose of morphine. And I'll go, you idiot. No, why are you giving him morphine? You have to figure out why he is in pain. We can't just because the pain's there and we're making it go away doesn't mean, what's your differential? Tell me your differential. And then you go, oh, well, maybe he hit his arm. Okay, maybe he hit his arm. Yeah. Maybe his arm was hanging over the bed and he has like a nerve thing going on. I was like, okay, maybe. Yeah. Anything else you want to think about? Well, he's got weakness. Can we think of a stroke? Yeah, maybe he's got a stroke, dude. Yeah, maybe we should order a CT head stat right now. And fine, you can give him morphine, but let's figure out what's going on with this patient because you almost killed this guy. And he'll go, oh, sorry. I'm nicer to my interns. But ultimately, you're trying to solve problems, but you also have to solve them critically, and you have to use your brain and actually think about what's going on with the patient, right? So then that'll. I'll be on a texting basis with my attending, and I'll say, hey, attending, just letting you know this patient's having this, and this. I'm going to go ahead and order CT. And if you're a good senior, if you're a good resident, the attending will say, oh, okay, yeah, that sounds good. Good idea. And they'll do it. And then they'll follow up. Later in the day, they'll follow up. So meanwhile, on the other end, Bobby, the intern, has put in an order for 0.5 milligram of morphine. So that's going to be sent straight to the pharmacy. That's a control. The pharmacist will go, okay, half a milligram of morphine. Let's check their weight. Let's check, blah, blah, blah. Okay, that's an adequate dose of morphine. I'm going to approve it. So now the system says approved. They take that medication and they scud it up through the scud system to the floor. And the floor goes ding, 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 ding. And the nurse goes, oh, my med is here. She goes over, gets the med. She looks at it. Should I be giving this morphine to this patient? And she kind of has an epiphany and goes, wow, morphine, he could get addicted to this. This is such a terrible drug. I don't know. Is this the right thing? I'm making a joke. Ultimately, she takes the morphine and gives it to the patient because she wants to make him feel better, right? So those are the layers of protection that happen. And then, of course, there's protections within the EMR health system as well. If I put in, right when I put in an order as an intern, if I put it in and it just seems wacky off based on the weight, based on the vital signs, whatever, the system's going to go, yo, this guy's like blood pressure is super low. Are you sure you want to get, yo, that dose is way higher than you want to double check it. So you can either go double check it or you can override the system, because a lot of times it's just a computer system that's like following algorithms. So my brother's cat is just like clawing at the window over here. It's not even my cat. Just like, is he gonna jump out the window? Do cats do that? Do they like claw? I don't know. I have a dog. I don't have a cat. He's making noises. So basically that's what happens, okay? That's how many layers of protection you have. But it's also a great learning system, because if the pharmacist gets that call, he's gonna call back the intern and say, yo, intern, you gotta check your work, homie. Like everything is off, man. Why are you doing this? And if the intern knows what they're talking about, says, yeah, I know, I meant to do that. Here's why. The pharmacist will go, oh, I got it. Okay, approved. Or the intern will go, oh, you know what? You're so right. Like, thanks for reminding me. Now I know the correct dosing for morphine is 0.1 milligrams per kilogram. You know what I mean? So it's a big learning system. These academic hospital centers you could think are dangerous because, you're having all of these learning doctors and learning nurses, everyone who's learning, putting in orders and doing things at patients, but ultimately you're having so many people checking and keeping an eye on what's happening. It's arguably safer to some degree. So there's one question. Was there another question, or was that it?
No, yeah, we can keep going. So it's cool to see like the kind of the interconnectedness of the hospital and how everything's kind of like backed up against itself. Now, can you tell us about like, I think probably most of your experience comes from a teaching hospital, but like the autonomy that you see in terms of like how much you can do versus how much is kind of taken over by attendings or fellows above you? Like what kind of autonomy do you have in patient care?
So I think this is a good question for a med peds doc, because I think wherever you go, ultimately you're going to have way more autonomy as an adult doctor than you are as a pediatric resident. And that being is because lives are a lot more delicate and their bodies are a lot more delicate. So you have to really be careful about what you're doing to them. And not only that, you can really traumatize them for life. So usually the nurses are a lot more protective, I think, on the pediatric side of their patients, because they understand the impact that, our actions can have on them are. So as a pediatrician, as an intern, you have very little autonomy. You can put in orders and make decisions. But ultimately, everything's risk, and you have to check with your senior or your attending or your, somebody before you do it, because, the repercussions can be really bad, right? In the adult world, you can really do anything, right? So at my hospital, for example, if I want to start somebody on CPAP, I can just do it. There's no issue. I can just call the respiratory therapist, put the patient on CPAP. It's not a big deal. At other hospitals, I don't know what that is. I don't know if you have to run through somebody to do that. If you're in, like, what's another crazy thing? If I want to stick a Foley catheter, you guys know what a Foley catheter is? To have someone urinate through a tube. If I want to go ahead and stick that up a person, I can just do it. No one's going to stop me. No one, obviously you'll get in trouble if you're doing that not at the right time, right? But there are these not invasive, but big things and moves that you're doing that could actually really affect patient care, right? You could blow a pneumo in somebody with a mask, right? So all these things are not so benign. You might think putting somebody on oxygen is not a big deal, but you're creating free radicals and you can have damage, especially in kids. So there's always levels. Again, there's always levels that are going to check you. Even when you have that autonomy to make those moves, there's people that are still going to check you. Now, there's always still mistakes that are made, and those are reportable, and we have to figure out what in the system we can do in the future to prevent those mistakes from happening again. And that's why we create things, alerts in the system. Oh, that seems way too high of a dose. Oh, this seems like a weird drug given these patients low blood pressure. Oh, this seems like really odd to do because the patient's heart rate is super high and that's just going to make it go higher. Are you sure you want to do this, right? So you got to have those systems in place, to put a check on that. Now, if I want to go and intubate a patient, even as a fellow in the ICU, as somebody who's higher up than a resident, I can't do that in this hospital unless there's an emergency and there's nobody available. I otherwise call anesthesia, right? So that's maybe is more of not of a question of autonomy, but of what the organizational practice is, right? Whereas in other hospitals, if I'm an ICU attending, I can intubate whoever the hell I want, right? In the ICU, in the neonatal ICU, where I just worked with brand new old babies, I had to intubate a kid last week. And obviously, that's a huge deal when you're intubating a baby, let alone anyone. So I had to check with my fellow. I had to check with the respiratory therapist. They all had to be in the room with me when I did it in case I failed, right? So I went in, I missed it. I went into the esophagus, we pulled out, bagged the patient for a little bit, gave him some oxygen, moved the mask off, went in again with the laryngoscope, got the tube in the larynx, and checked for sounds on both sides of the lungs to make sure the tube was in correctly. And ultimately, it worked out, right? But maybe that wouldn't have gone so smoothly if all those people weren't there to guide me and catch. It's like, what if I didn't get it, right? What if I went in and I blew a pneumo? A pneumothorax, by the way, I'm saying all these big terms. A pneumothorax, where one side of your lung like completely collapses, where you have air essentially not in the lungs, outside the lungs, and it pushes on the lungs and makes them smaller so that you can't breathe, right? So you got to think about all these things with safety. So autonomy is a really big and kind of hot, not autonomy, excuse me, patient safety is like a really hot topic now in medicine. And there's patient safety boards and there's boards that go beyond patient safety, that go beyond, is this the right thing to do for the patient, even though we can do it? Is it the right thing? So that's why I kind of going back to my conversation before is that medicine, it doesn't just have to be like a clinic. Who the heck keeps calling me? It doesn't have to be like a clinical field, right? It can be an administrative field. It can be a policy changing field, and it can really be anything you want. You can go into research. You can be go into farm and make $1 million a year if you really want to. You know what I mean? So it's a cool field, and it gives you a lot of options if one path doesn't work out for you. Did I answer your question?
Sounds like you've got a nice, yeah, definitely. It sounds like you got a nice blend of kind of autonomy, but at the same time, other people looking over your shoulders, making sure you're doing everything right.
Exactly. Exactly.
Can you tell us a little bit more about what made you choose between meds peds? I know you said you liked working with adult patients and younger patients, but was there like a specific moment that you had during med school where you were looking to match for residencies that kind of led you along this path? Or was it kind of something you always knew you wanted?
Yeah. I shadowed a family doctor before I went into med school, which I recommend everyone do. I would say family medicine is probably the best field you can shadow in, even if you don't want to go into it, is because it's going to expose you to massive amounts of medicines and a huge breadth of what you're going to see, unless you have med peds too. But see every age, and you're going to be able to see pretty much every condition to a certain degree, right? Like even as a med peds doc, let's say I wanted to go be an ENT doc, an otolaryngologist. I have this kid who's coming in for, large tonsils. His uvula is like deviated. He's got a muffled voice. This kid needs surgery, right? So I'm seeing an ENT condition that I'm going to need to refer to an ENT doctor for, right? And even and if it was an emergency, I would need to act and do, the minimal training I have in comparison to an ENT, I would be able to do it right there, right? So you're seeing everything, even the specialist fields doing this general practice medicine, which is why I love general practice medicine. It might not be as sexy as a field as surgery or as dermatology, but I'm like living that doctor life. I'm able to treat any condition I want. If anyone calls me, and I have my friends, if I'm in the middle of a plane, in the middle of a desert, I can treat your condition, find things around and do something with it. And I think that's way cooler than making a $500,000 a year. You know what I mean? So that's where it was more important for me. But ultimately I used to want to do family medicine, and I actually applied family medicine And then halfway through the cycle, I was like, wait a second, like I'm kind of learning now that family medicine is more outpatient. I think I want to be an inpatient doctor. I think I want to work in the hospital. This is way more fun. I can intubate people. I can do CPR, respiratory. I can make quick moves. I can save people's lives. And I can do a little bit of that counseling that I'm doing in the outpatient setting. I can do a little bit of primary care. I can do everything. It's like everything plus everything. So I was like, I'm going to do med peds. And so I interviewed at, I don't know, like 25 or 30 different family med and med peds programs, and ultimately ranked. It's a ranking system, the way that you choose what school and what residency you go to. And I ranked med peds programs higher, and in my top program. So I was really happy. But I could have very much ended up in family medicine as well. Something also to think about when you're applying to a field is the personalities you're dealing with. If you're okay with big-headed personalities and competition and kind of a cut-throat environment, you have to think of not only what field you're going into, but what the hospital culture is like that you're applying to, and ultimately what you want out of your day, right? We're all practicing medicine, right? The surgeon's going to be cutting all day, maybe going to be thinking about the cutting, but also thinking about everything else and every other organ system. So ultimately what's going on in our heads is somewhat similar and different, but our outside world that I'm visualizing and I'm seeing every day is going to be different too. But really what matters is your experience of what's happening. So even if you love otolaryngology, you want to be an ENT doc, you love ears, noses, and throats, you've thought about ears, noses, and throats your whole life. You obviously like the nose more than the throat, but the ears excite you at some times as well. You got to say, like, listen, am I in a year going to be sick of ears, noses, and throats? And maybe I'm going to want to do a little bit more cardio care. So maybe, even though I like that, maybe this is not the right field for me. Maybe I like cutting a little bit. Maybe I like that surgical aspect. But, actually I was reading that in the ICU, there is a little bit of suturing. There is a little bit of cutting. There is a little bit of intubating. There are procedures so I can still get that hands-on work over here and also love what I'm experiencing in my head more than what I'm going to be experiencing in my head over in this field. Does that make sense?
So I think that's a really interesting look on general practice medicine. You get to look at a lot of different, you said, like, you get to look at a little bit of every different specialty, and you kind of know a little bit about everything, which is nice.
Mm-hmm. So yeah, totally. So just think about it from every perspective, really put in the shoes of what you think that job is, shadow someone in that job, see if it's exactly what you think it is. And if it is, ask them what they think about it. Do they love this field for this? Are you going to get, so if I'm thinking I'm going to get a lot of this out of a field, go ask that doctor, are you getting a lot of this out of a field, or is that not what this specialty is about? Figure out if that's what they're really seeing. Don't assume that what they're seeing is what they're seeing.
All right. And do you have more after this slide? We can keep going with your presentation.
I do.
All right. Let's keep going then.
All right. We're at 45 minutes in.
Yeah. So we'll spend the last looking at some patient cases.
All right. Let's do it. This is a fun one. All right. So here's a cute little stock photo I found. Obviously a great pic. He's got a little blue stethoscope. He's got a little, he's checking his teddy bear. That's very cute. How many months do you think this kid is?
8.
3 months? Yeah, I'd say anywhere from like 4 to 6 months, I'd say 4 to 7 months. I actually don't know the answer, but that's what he looks like to me. All right, next question. Let's go to the next one. All right, so the chief complaint. So my screen is in the way here. 14-year-old male. He doesn't have any past medical history. That's important. You always want to know what their past medical history is, because they might just say right there what their problem is, right? If I'm dizzy and I have a history of diabetes, I'm probably low. I should just check my blood sugar. I don't really need to know this whole history, right? So that's why we say it in that first line. So 14-year-old male, no past medical history. He's coming to my ER after he went to his outpatient doc today. He's had 20 days of fever. It's a really long time, dude. I don't know why you just saw somebody today. That's kind of whack. All right, next slide. That's a cute dog, obviously, with a little like cooling pad on his head. History of the present illness, which is just another term for just tell me a little bit about what's been going on. Fever every day, usually at nighttime. His fevers have gone up to 103, which is fairly high temperatures, fairly high. He's also had some night sweats. He's got headaches. He's got malaise. Do you guys know what malaise is?
Isn't it just when you feel like icky?
Ah, yeah, like fatigue, like tiredness. Yeah, icky. Icky is the medical term. Good job, Grace. Dry cough, anorexia. Does anyone know what anorexia? Let's hear it. You guys are in the video. You guys have to respond.
Is it just when you it's a disorder, like an eating disorder, where you don't eat enough because you have like body dysmorphia?
That's good. That's anorexia nervosa. Anorexia itself, as a medical term, is just a symptom for not wanting to eat. So it's similar to anorexia nervosa. That was a trick question that you fell right into, and I'm glad you did. Weight loss, diarrhea, and it's non-bloody and non-mucus. Mucousy and bloody diarrhea, and that can point you in the direction of certain bacterial pathogens and parasitic pathogens and fungal pathogens. So he's also had a fever and symptoms that improve with Tylenol. So Tylenol is a really good antipyretic, which means it's anti-fever. And that's good. So he's been taking this Tylenol drug and it's been lowering his fever. So that's awesome. I'm glad he got some relief, right? 20 days of fever is whack. So he went to Pakistan for months, he had a 14-hour layover there. And he saw his primary doctor a week ago. Okay, good. So he saw it a week ago and he got a 10-day course of amoxicillin for strep throat, which is like pretty much the common treatment for strep throat, which is streptococcus as a type of bacteria that causes, you guys have maybe had strep throat in your life. It's absolutely terrible. It's a terrible, terrible condition that usually needs antibiotics. So he did antibiotics, good for him. All right, so clearly it didn't fix it because he's back. Next slide, por favor. All right, so review of systems. All it means is I'm gonna ask you questions based on my experience, but let's just use a systematic approach. So this is like a preset review of systems that I use for all my patients. I go through this to make sure I didn't miss anything. So we talked about fever, weakness, fatigue. We talked about weight loss, night sweats. We covered cough, nausea, vomiting, diarrhea, anorexia. So he's also had a headache. I didn't ask him that. So, okay, good. So my review of systems, I've covered that. And all this other stuff is negative. Only the red stuff is really the positive stuff. Otherwise, no nasal congestions, no chest pain, nothing like that. So that's good. All right, next slide. All right, these are his vital signs. So his temperature is 38.1. Does that seem like a normal temperature to you?
Like a slight fever, right?
Yeah, what's a normal temperature?
37.
Yeah, around 37. That's good. We're talking in Celsius. I thought I was going to stump. I didn't stump Nicholas. Okay. Maggie, you're the only stump one now, so shame on you, man. I'm just kidding. Heart rate is 116, which is elevated. What's the normal heart rate supposed to be, guys?
100.
Yeah, so 60 to 90 in most age groups. The younger you go, you can, newborns can go up to like 200 and be normal, even more sometimes. So it depends on your age, but he's like basically, 14 or 15, I forgot. Respiratory rate is normal. You want to breathe about 12 to 20 breaths per minute as an adult, so it's normal. His blood pressure is 83. The lower end of blood pressure is like 90, so that's scary. Whenever you have somebody with low blood pressure, you got to act very, very quick, very quick. That's a very bad vital sign. And his diastolic was low. So systolic and diastolic are just 2 points of blood pressure. Kind of think of it as your highest and your lowest blood pressure. Okay, next. And his pulse ox was okay, meaning that he's got good saturation. So physical exam, I'm just generally looking at him when I walk in. He seems okay, doesn't seem upset. I looked at his eyes, I looked at his ENT, I looked at his, listened to his lungs, listened to his heart, listened to his belly, looked at his muscles, his skin. He seems good. He seems like he's doing well for the most part. Nothing obvious popping out to me. So what's going on with this kid? Why are his vitals weird, but he looks okay? Any questions at this point? All right, rock and roll. Cool. What's the medical term for what this patient is experiencing? He's got a fever. We don't know where it's from, and it's been going on for 20 days. Do you guys know what the term is? Have you heard of it before? It's not medical sounding at all. Sounds like somebody who just like went online on Google did it. It's called fever of unknown origin. It's like a very generic term, all right? So this kid's got a fever of unknown origin, which is FUO. So just means I don't know what this kid has. It's basically doctor talk. All right, so there's a nice little book there. Looks like it's a medical book with some cool glasses there. Nicholas is like, all right, he's just blabbing on. I'm just gonna go to the next slide. That's like my jokes, man. This is what I do for my jokes. You're killing my joke game. All right, so greater than 38.3, so greater than 101 degrees Fahrenheit, at least for a week. Is FWS, that's beyond your guys. You don't even know about that. All right, next. So look, this guy's funny. He said I said FUO, not UFO. Grace didn't even laugh. She just chuckled. If Grace doesn't laugh, I feel so bad about myself. All right, next question.
I'm keeping the joke going. We'll let it go for a little bit
All right,
longer.
he's gonna keep the joke.
I do laugh decently easily though.
Okay, you do. I know. I've been seeing it. That's why I'm using you. You're like the threshold. If I haven't hit you, it's like really bad.
It's weak, yeah.
It's weak. Oh, ouch. Okay, what could be some of your differential diagnoses? What do you guys think this guy has based on your going to college up to third year?
Considering that he can't eat, or he's not eating, and he's diuretic, and he went to Pakistan, I would think some type of like worm, maybe like a stomach worm or something.
I like that. That's really good. That's really good. Could be. All right. Nicholas and Grace, I need one from each of you. If you get it wrong, it's totally fine. No one cares.
I was going to say like a GI infection or something like that.
Okay, a GI infection that might not be from a parasite. Okay,
right.
I like that.
I was also thinking infection, but like viral, since we already tried.
Viral. Okay, cool. Yeah, so there you go. So you guys really stuck to infection, but you have to remember with fever, a lot of different things can cause fever, right? So usually it's an infection, right? But cancer can cause fever. Sometimes certain types of clots in the body can cause fever. You have viruses, fungi, bacteria, parasites, all sorts of things that can cause fever. You can have heat stroke type of fever, right? If this kid's been out in the sun, obviously that's not the issue. But all right, next slide, please. So here's a differential, right? So you can kind of break up any differential diagnosis or any symptom into a different. So they broke it up into an infection. So you guys said something like a worm. Let's see, is there a worm that they wrote in there? I don't think there's a worm. I don't see a worm in there. But yeah, it could be a worm. I think that's fine. They're saying a UTI, which is a urinary tract infection. They're saying these non-organ specific ones are the interesting ones. So brucellosis, Q fever, salmonella, Yersinia pestis, tularemia, septic phlebitis, rheumatoid fever. Don't I sound smart saying all these big words? So the list goes on, and you really have to know everything about the patient. So the what I always say is if you're not 90% sure about what your patient has before you've done any tests, then you need to go back to the patient and talk to them more, because you can really diagnose everything from a patient just by talking to them, right? If my mom calls and says, I have a rash on my back, Jeremy, what is it? Over the phone across the country, I should be able to diagnose it pretty much, because one, she's going to keep calling me and bugging me, asking me what the rash is, right? That was a joke, Grace. And two, she probably has had this exposure. I know my mom. So you should be able to get a history and be able to tell what's going on. So we got a good history. So Maggie had this guy came from Pakistan. So we should keep that in the back of our minds, because there's a lot of different bugs that live in Pakistan that are not in the state of New York. And if it just happened when he came back, I mean, that's kind of suspicious, right? That's kind of weird. Okay, so look at so you have all these different sorts of diagnoses and pathways you should go down. So we'll ask about family history. Maybe there's like a rheumatoid arthritis or a lupus in his family, or a drug fever or something. So take a good history. All right, next slide. Ooh, look at that, ER. Is that George Clooney on the right there? I don't recognize anyone else. So I think this was a show on TV before. I don't remember. I'm not a grandpa. So what do you want to do for this kid? We'll start with Maggie. We'll just go down right to left, or left to right. Maggie, Nicholas, Grace. So what's one thing you want to do for this guy?
I think you mentioned a fever reducer, so just get him started on some type of fever reducer for the pain.
Smart guy. You should go to med school. You're smart. All right,
Thank you.
Nicholas, what about you?
Well, I would be concerned about the low blood pressure also, like you said, it was like
What are you gonna do?
89/51 or something. So
Yeah.
like look for some murmurs or something like that.
Okay, so yeah, I mean, a type of shock is one can be cardiogenic. It can be related to poor functioning of your heart, but if you have infection causes what you think is the cause of it, it's usually like a distributive shock. So like or like a septic type shock from infection. So it's just your arteries and your veins are kind of relaxing, so your blood pressure is low. It doesn't really have to do with your heart. So if it did have to do with your heart, I might give him something that'll increase the contractility of the heart. But if it's just in the peripheral, I would, if in the veins, what the guidelines say from like resuscitation guidelines are essentially just to give fluids. Just give a lot of fluids, fill up all that new space that's been formed by the veins opening. And then if that doesn't work, then you give them a drug that'll clamp those vessels down instead. Okay. All right, Grace. No pressure. You got the toughest one because they like covered a lot already.
I know. Okay, you said talking about asking the patient more questions. So, and then you also mentioned bugs. So now I'm thinking of like malaria and asking the child
Ooh.
where he was sleeping or like if any
Ooh.
with had any symptoms or.
Good job, Grace. Yeah, good. So getting more history for sure, for sure. Definitely. So I think you're kind of leading again down that infectious pathway. So in the ER, right when I see this patient, I'm gonna get blood cultures, right, just to see if there's anything growing in his blood. Maybe I'll get urine cultures, sputum cultures from what he spits out. I just want to grow something so that in a few days I can give him something. But right now I got to give him this super strong antibiotic that'll cover most things that I think he has, but might not be specific to his bug. So what we typically give, one is ceftriaxone. So we gave this guy ceftriaxone, which is a type of antibiotic, just to cover him until we grow something in his blood. So you can do next slide. All right, so this slide is really just talk what labs you're going to do, which we did all the labs. We did cultures, any sort of imaging you want to do. We did a chest x-ray on him. We'll talk about that in a sec. And just determining based on that, does this guy need to be in the hospital or can we do all this stuff? You know, can I just send him home and, you know, to the primary care doctor tomorrow and have them figure it out? What do you guys think we should do in this case?
I mean, he's had a fever for like 20 days, so probably keep him around because it might be a problem.
Yeah, but more importantly, what's going on with his vital signs right now? What's really concerning?
The elevated heart rate and low blood pressure.
Yeah, his blood pressure, right? His heart rate's probably just elevated because his blood pressure is low, right? So if the heart is saying, okay, the body's not getting enough blood, I'm gonna just pump faster, get that more blood to him quicker. So it's just a response. So the tachycardia doesn't concern me as much as the blood pressure does, because that's probably what's causing it. Okay. Now you can also have the opposite, causing a low blood pressure as well. But you know, that's for medical school. That's for later when you guys get into a doctoral program. All right, next one. Whoa, look at all these labs. So there's a bunch of labs. I'm not going to go through them all because it's kind of beyond, but just to have an idea that there's a lot of labs we take, and this is like normal labs. This is like pretty much what everyone gets in the ER for the most part. So stuff that sticks out to me is hymns a little low, which can be a sign of poor hydration. Woo! I sneezed. Doctors sneeze too. I have a creatinine. That was stupid. I thought it was funny though. We have a creatinine that's a little elevated. That means there's a little bit of kidney failure. So usually due to fluids. His liver functions are a little elevated. Sometimes that can be from having a. And most importantly, if you look at his WBC count, his white blood cell count, it's normal. It's not red. So we're like, does this kid even have an infection if his white blood cell count's normal? Because normally that's elevated. All right. So we're even more confused after we get these labs. Here's some more labs. We took some coagulation factors. If you look at the bottom left, some newer labs in the past 10 years, CRP and procalcitonin are kind of tricks to tell us if there's an infection, if there's something weird going on in the body. They're just like general inflammatory markers. And they use these ones in COVID a lot. to figure out if somebody needed antibiotics or needed certain drugs. And then of course we have our viral panel on the left. So maybe you guys have heard about some of those viruses. I'm sure you can see COVID-19 at the bottom there. We tested them for influenza, coronavirus, rhinovirus, a common cause of the common cold. So we did a lot of tests. Is this making sense, guys? Yeah. So this is the chest x-ray, okay? What's that big thing in the middle?
It's the heart.
Okay, Nick. Don't talk down to me, Nick. How dare you? Of course it's the heart.
Sorry.
It's a heart. And do you think this is a normal chest x-ray or an abnormal chest x-ray? I don't expect you guys to know. I'm just curious to see what you think.
I mean, I don't see anything obviously bad about it, but I'm cautious to say that it looks normal.
What about those things? You see the little spider webs on the side of the heart?
Well, is that a collapsed lung?
No, collapsed lungs don't really look like that. Those are actually just normal pulmonary markings. They're a little thicker than normal, but it's like a normal variant. So usually if you had somebody in like heart failure or with congestion in their lungs, they have a little bit more of that spider webbing. But his lungs sounded clear, and sometimes the x-ray can just be shooting a little bit harder than you want, so you can get weird artifacts in the photo that you might not necessarily take into account. Okay. Oh, yikes, what happened there? The photo got in the way. What interventions does this patient requires, I think I wrote. And here's a cool picture of somebody running into the emergency room, and it was just poor exposure, and so it's blurry now. So we have that kind of feeling of this is an emergency. So that's a little bit of art for you. Don't put pressure on yourself that you're not artistic like me. You know, hopefully you'll get there, but you probably won't in your lifetime because I'm very talented. All right, I'm done. You guys were laughing the whole time, so I kept going with that joke. All right, so I told about the interventions. We gave them some fluids, right, for the blood pressure and the tachycardia. Good job. We gave them some Tylenol, good job, Magdi, and we gave them some ceftriaxone, 2 grams, of course, right, Grace? Good job going down the infectious route. She got the thumbs up from Grace. Good job with the ceftriaxone. All right, and there's a picture of my hospital. What a beautiful place. What a depressing, terrible place to work. Next slide. I'm just kidding, guys. I love it there. Patient was admitted to the pediatric floors. Here's a cute little picture of some kids. They're all in kind of this matching outfit. I guess one has a drum hand. And what does that kid on the left have? Is that a piece of a watermelon? What is that thing?
I honestly thought that was a grapefruit, and I can't tell.
Dude, what is that? I don't even know what that is. All right, whatever. I guess sometimes you just don't get the answers you want in medicine. So, all right, here we go. So the guy had salmonella. Have you guys heard of salmonella? You guys probably heard it from eating uncooked chicken. It's like your classic, your mom is like, cook that chicken. That is not cooked enough. Cook that fish. It's not. I know that's what my mom used to say. So salmonella. Kid had enteric fever, which is just a type of salmonella. You can get it from certain foods like chicken. You can actually get it from contaminated water, right? So Pakistan is underdeveloped in some regions, so you can, if you drink the water there, you might get it through the water. Also, interacting with certain animals, you can ingest it as well. You know, fecal oral route. Fecal meaning you touch your mouth. So if some animal went somewhere, or you touch something that some animal touched, essentially everyone goes like this with their mouths all the time. So fecal oral route, meaning it's transmitted from fecal to oral. I think I explained that enough. I really just killed that explanation. Enteric fever is more common in children and young adults and older patients. That's true. Humans are the only reservoir, meaning we're really the only ones that get infected by it, but there's a lot of animals obviously that carry it. And we have about 200 to 300 cases a year in the US. So I had one of those cases. That's kind of a big deal. If you're really only seeing 200, 300 cases, and there's something like 6,000 hospitals in the country. So your chances of seeing it are very slim. So it's interesting. I think I have some more facts on the next slide here. If you guys have heard of Typhoid Mary, she was a chronic salmonella carrier. So she would go from house to house cleaning. I think she was like a maid of some sorts or a cook. She was a cook. and she kept passing it on to these families. And I think the health department at the time was trying to get her to stop, but she like wanted to make money, so she just kept giving it to everybody. So she was a chronic carrier, meaning it was passed in her stool and her urine. So she was probably scratching her butt and then cooking in the food, and then, you know, her family was, or not her family, but the family she was treating were getting it, right? So an issue that's come up is, you know, typically we treat it with fluoroquinolone. Have you guys heard of ciprofloxacin before? No, yeah, I don't expect you to. So that's like such a, I don't know why I asked that question. So ciprofloxacin is a type of fluoroquinolone, which is a type of antibiotic. They've been used to treat this bug, but unfortunately the fluoroquinolones the bugs have grown resistant to it because we've used the drug so much. So now we can't use that drug. So in Pakistan, they've used it quite a bit. So this guy came back from Pakistan and he had this bug that was like resistant. It was a resistant organism. So we had to figure out something to give him. So the ceftriaxone, we had guessed he had salmonella coming in. We have a really smart infectious disease doctor. And they gave him the ciprofloxacin, or rather the ceftriaxone, knowing that he probably had this resistant bug. So he probably got it from ingesting water or eating some sort of food or having some interaction with animals there. I'm not sure. Okay, next slide.
Quick question. I don't mean to interrupt.
How dare you?
Okay, you see this like 200 to 300 times a year in the US. Do you know this antibiotic like off the top of your head for this very rare condition, or do you like look it up when you're there?
Grace, what do you want to do? What kind of doctor?
I have no idea. Very open-minded.
Okay, good. Yeah. So you do have to memorize as a doctor, or you should memorize what everything treats. Now, when it comes to resistant organisms, there's no memorization pattern. Ultimately, the only thing that you can do is grow it in a culture and zap it with different sorts of antibiotics and see which ones it doesn't survive from, see which ones actually kill it. And only then you can choose that antibiotic. So you basically put it in a bowl, see what you can kill it with, and then take that bug and kill it in the body, right? So there is a website called Up to Date. There's a lot of resources online, like AAFP.org I told you about, where you can get access to this information. And as a doctor, you got to be reading every day. You got to be reading medical journals and being up to date, because this stuff changes constantly. It's not like I go to medical school, I do residency, I'm done. It's like you're studying all your life. So, I was like, oh, it doesn't matter how many years, I'm just going to do it. So, that's to a degree, you are going to be studying, the rest of your life. But, just something to keep in mind. So there's different stages of the illness. And obviously if you go untreated, which this kid was about to go into week 4, you could have like fulminant sepsis, and you could have perforations in your gut and essentially be septic and die. So it's not something to mess around with. All right, that's interesting. All right, next one. Here's a rash, little speckles of red you can get sometimes. This kid didn't have it, of course. He was a mystery. Made us look all like idiots because we couldn't figure out what was wrong with him until the culture told us. Next slide. Leukopenia means low white blood cell count. Leukocytosis means higher white cell count. He had neither, so we were very confused. Transaminitis means liver function tests were off. Your elbow, man, you've got a sneaky elbow that just keeps. So the transaminitis means elevated liver function tests, and essentially that's what this kid did have, but that's pretty generic. Elevated inflammatory markers, anybody could have that. So he had some of the findings, but not really enough to really put us in the right direction. Guys, it's getting late. Should I finish? There's about 5 more slides, or should we call it?
If we just run through it really quickly towards the end, and then we can kind of wrap it up.
100%, yeah, 100%.
Cool.
We'll go quick. I think I'm almost done. Next one. All right, so the way you figure out what it is, like I said, you get cultures of everything, and then you just see what it grows. That's really much it. There's antibody tests you can do, but they're not very accurate. So we just do cultures. Next slide. Put that elbow into action. Thank you, my friend. All right, so like I said, we usually treat it with ciprofloxacin, a fluoroquinolone, but this one was not sensitive to it. So we picked ceftriaxone. And there were some other options you can see there under antibiotic. That's pretty much the mainstay of treatment. If it gets worse and worse and worse, you end up in the ICU, and pretty much everyone's on everything: steroids, antibiotics, antifungals, ventilatory management. So you really, as diseases get worse, they become kind of similar in a lot of ways, and you have to just like critically treat patients. So antibiotics is the answer. Next slide. Okay, so here's my dog Zeus looking awesome in the snow. Thank you very much thank you, Nicholas, Maggie, Grace, and Shellcast Shadowing. This has been a really, really awesome time.
Thank you so much for coming on. And just a reminder for everybody, we have the quiz link in the chat right now. It's also in the bio on our Instagram, so make sure to check that out. There's a 48-hour time limit, so if you couldn't make it now, always can rewatch in the next couple of days. Thank you for coming, everybody. Make sure to check out the link in our bio for everything else. Have a great rest.